All right. So I've added some slides from what y'all can see on the website or on Navigate just to kind of help with things. I felt like we're important. Sorry, I'm super tired. Long story short, it's probably been, we're working on 18 hours right now a week, so I'm a little tired. Pharmacology, we talked about the fundamental knowledge of medication that EMT may assist or administer. Remember that as we go through this. You can assist or administer to a patient during an emergency. Medication, we want to talk about medication safety, kinds of medication used during an emergency. We're going to go over the difference between self-administered medication, what peer administration, and then assist administered. So those are the three different types that kind of really what we're going to focus on uh, as we go throughout this chapter to kind of let you have a more understanding of what, who, what, when, where, and why of the. Sorry, I was trying to get everything situated on my screen. Of kind of a little bit more knowledge of the breakdown of the EMT medication. So talk about the emergency medications. We're going to go over the names, the effects, actions, indications, and contraindications. You all should have an idea of what contraindications are, just because we've taken medicines before, and we should know, like your doctors have spoke to you about other classes. Hold on 2 seconds. They've talked to you before about some contraindications about certain different medications. So y'all kind of have a vast knowledge of personal information when we start talking about contraindications and indications for taking it and what are the actions of taking medication. We talk about some complications, routes to administer, side effects, interactions, and dosages for the medications administered. Those are all super duper important because you're going to have to remember these when it's time to make your notes. So we got to make notes on which ones are going where. Medications are more important. Intervention, medications may alleviate pain, improve the patient's condition. Even if it does not improve the patient's condition, you still have to note it once you gave it like a 5-minute, 10-minute window on how long of the medication, what it did it improve the patient's status? Did it deteriorate? Or you just need to know so that it's part of that patient's report. And I mean, it's important to make sure you document that. Fair administration, administer the medication safely and complete can lead to serious consequences for the patient. I added in there, EMTs only administer or assist with drugs that are listed in their protocols with medical direction approval. That's super important too, because you can't just walk up and be like, oh, well, I'm gonna give you some, you know, diphenhydramine, and it's not called for. It's you can't give that medication to begin with. Um, so let's talk about how medicine works. So pharmacology is the science of drugs. Um, we know that medications are made in different forms. They help prevent, let's say, headache medications, just to help create the pain relief. They do treat some diseases. That could be a whole different topic, I'm sure, with every one of us. But pharmacodynamics is the process by which medication works on the body. So we want to know, like when we take a medication, the process of it. What does it do once it makes it to the stomach? Where does it go from there? How does it help the body? So that's why pharmacodynamics is important, and you learn a little bit of that until you go into the paramedic world, because you need to know what that epinephrine does, how it affects the body, where is it going to trigger for, what is the half-life of the medicine once you give it IV or IM. Those are important because then you have a, oh, I'm sorry, y'all, I'm super tired tonight. So, but you already have a baseline knowledge of that medication, and you're like, okay, if it has a half-life of 10 minutes and it's a half potency at 8 minutes, well, then you know you're going to be given that drug over and over and over. So that could be, that's something you need to keep in the back of your mind about that medication. And then again, we talk about pharmacology is the study of drugs. So these are importance in here. I've got some information in there too. An agonist is causes stimulation of receptors. I'm knocking early, just so y'all know that. So antagonist binds to a receptor and blocks other medications and chemicals. I'll go further into that in just a little bit. What we want to know about the dose of the medication is, depending upon if it's an adult, pediatric, or whatever else, you still need to know their weight. Kids are more known into kilograms versus poundage. So if you can know their weight, you divide by 2.2 gives you a kilogram weight. So that's something that's important. Their age, each age group will get different dosages of medication versus where we may say you may get 1,800 milligrams as a regular normal adult, but being elderly, you may not you may not get that dosage if you get it older in age. So you may have the reason the importance of the age is because of that. Desired action of the medication. What do you want it to do? What is the general purpose for you to say, okay, I need to give this medicine? Well, why? I need to know why you want it. And what is the therapeutic effect that the medication is expected to have on the body? Well, again, so if we all take ibuprofen, well, are we taking the ibuprofen for the anti-inflammatory effect, or are we taking it for the pain relief? So it has both of those. So that may be changing from a Tylenol due to well, I have a headache and a backache. Well, I could potentially fix both with one medication. And you need to just know what your normal daily max dosage of that drug is. I mean, we can only give 1 gram of any OTC meds in a 24-hour period. So knowing that and trying to educate your patient on some dosages / what they're taking at home, it's just an education process that we're teaching our people. And that's just as important with day-to-day interactions of patients, because there's probably not that much education that's given to them from these pharmacies. So the more you know, the better off you can have. Rebecca says, are pocket drug formulas kept on AMSs? Tell me a little bit further what you mean by that, and I can answer that a little bit better.
So, basically, almost a cheat sheet of common drugs that you use, or maybe not even not so common drugs that are used, but the dosage, the age range. And then, of course, you figure it up yourself as far as how much to administer based on weight.
So it is kind of cool. Pediatrics are the ones that really have the most. They have this pretty cool thing. It's called a Broslow tape. So on a Broslow tape, they're color coded. If their head is from this range to their feet and they fall in, let's say they're purple. I like purple. That was my mom's favorite color. So, and when she passed away, I kind of taken purple. I wear everything purple. That's just remembrance about mama. So if they're in a purple and a range, you give so much drug you give a certain amount of each drug per category. Well, for adults, it's not really like that. It's really a set amount. If they are 18 or older, they set that. Now, a lot of services do hound your paramedics on knowing the drugs, the dosages, the routes, the administration route. So, currently, I can access all of mine by my phone through an app, but I need to know about 99% of mine on a normal basis. Now, there may be some that I have questions about. So what I use offshore, I can't use onshore. So that when I do work the streets, which is rare, I do get somewhat confused, but each service that I work for has an app with their protocols on there. I know what drug to use and what timing, but I can kind of Google or research, or not Google, but I can pull up the app for the company and know better of what dose that they say. Like 99% of your patients and ambulance services that go into cardiac arrest that have patients and they have a cardiac protocol, they're all going to be the same. They're not going to be like have some wild, crazy algorithm that you follow. It is pretty much the same. You may just have like a dose for Decadron that you can give at a certain time or rate for a certain issue that one service may not, just because their medical director likes that better in that algorithm. So yes, yes and no. I have my own Broslo tape that I carry with me back and forth to every service that I work for part-time, just in case, and it is a tool, not part of my everyday use. Maybe I'm jumping ahead, but one of the EMTs I work with just let me know that all first responders can only push 8 milligrams of Narcan. That all depends on your service. If you're, cause see, Narcan comes in an 8 mil vial, but you can get it from the store a lot higher. So it's each service is only going to allow you to do certain things. There may be a state standard. It depends on where you come from. You may have to check what your state allows that to be happening. So I don't know to answer that because it depends on what state you're from. I would check with my state. You can actually, Google New Mexico state EMS protocols, and they should be able to tell you. I can give multiple rounds of Narcan if required. I don't have to just give one and done. If that's something that I see that's needed. Now remember, if you give Narcan and you give it too fast, we'll go over Narcan a little bit. They will hate your world, but we'll go over that when we get into that. So Informal Kinetics, so the actions of the body upon the medications or chemicals. So what we want to know is action of onset of action, duration, elimination, and the peak. So how long is it? Stand by. I got another instructor. I forgot to give him some information. Whoops. Let's see here. Figured he needs this information, so it's going to take me just a second. I thought. Thought I sent this earlier, so that's all on me. Whoops. All right, so we want to know how long the onset of action is going to take. What is the duration of this drug? Is it a fast burn rate to where it means it's only going to be working in the body for maybe 2 to 3 minutes? What is the elimination time and the peak time? I need to know what is the peak range of this drug and how are they going to act when they started coming off of that? Those are important just to know the medication. Now, I don't expect you guys to be like, you're going to recite drug cards, because that's not where we are. We're not there to that point. Now, when you make it to medic class and you decide to come through here and that's something you decide to do and push through ARES, they don't like me because I require a lot of drug cards. So it's important too. That answer that. So factors affect of how medication works. So each medication is going to work differently, depends on its route. Well, some drugs can only be given IM and IV, or just IV. It just depends. So certain drugs are going to work better by IV versus oral or nasally. So knowing the best route for your patient too is also issues. Shock states, I'm not going to go into that. It's not that big of a deal. All right, so indications and the reasons of and conditions. So some of your contraindications are situations in which the medication would either harm the patient or have no effect at all. Your absolute contraindication situations in which medication should never be given if the contraindication is present, i.e., I'm highly allergic to iodine. Well, you don't want to rub me down with betadine as you start an IV. Don't want to do that. Relative contraindications, situations in which the benefits of administering the drug may outweigh the risk. So if somebody tells me that they are super allergic to morphine, well, what's it do? Well, morphine makes me itch. Okay, well, I can fix that. When you say itch, does it make your respiratory drive? Like you start, like your throat itches, or you feel like you're gonna quit breathing? No, I just break out in hive. Well, that's a side effect, not a reaction, because I can make you quit itching. I have medication that does that. So, but it may be better off that I give you the morphine to help with the pain. Make sense? I hope that I try to explain that little part better. Some of the adverse effects, any actions of a medication other than the desired ones. Well, you need to note that all of these are notable incidents. I don't want to say incidents, maybe notable outcomes of any medication. So unintended effects are their desirable but pose little risk to the patient. Okay, so you may give them medication, you're like, man, I feel like my chest is just beating out of my heart's beating out of my chest. Well, I need that to happen. That's not what I wanted. And then untoward effects is effects that can be harmful to the patient. So again, if they say I'm allergic to it and you give it because you're trying to use morphine as a pain medication and they quit breathing on you, now you done messed up. I mean, that's bad because you didn't take the time to ask enough questions for the safety of your patient. Just because that's what your protocols say, don't mean that everybody in the world is okay with that. So be a little careful. Let's take time to interview the patient or family. All right. So here's some medications that EMTs are commonly. Now y'all gonna have to look at this. Y'all can see the difference between this slide and this slide is bigger. Chris Wally can't read because I forgot my glasses at the house. So no pun intended. Y'all can't laugh. It is what it is. The slides are a little bit bigger. It makes it better for me to read. So oxygen. It is a medical gas that is indicated when you suspect hypoxemia, the patient complains of dyspnea or is in respiratory distress, the patient has signs of shock or poor perfusion, and the SpO2 is less than 94. So the SpO2 is your pulse ox. Somebody tell me what hypoxia and hypoxemia is. Now hurry up and Google it. He's talking to us. Google it on your phone real quick. I'm just messing with y'all. I'm gonna start calling out names. Let me get over here. I'm gonna call y'all out. Y'all too quiet tonight. Oh, where'd it go? All right, even if you don't say anything out loud, let's see here.
High and low levels of oxygen in the blood.
Perfect. You beat me because I was so fisting to say something. So high and low levels of oxygen. I just need to know, are they basically it's hypo or hyper, but it's very say hyperoxemia. That's just the type, hypoxemia is high. So when the patient complains of dyspnea, what is dyspnea? Caesar, you can talk, tell me, talk it out, doesn't matter. What is dyspnea?
Difficulty breathing.
Anyway. Oh, Rebecca, beat you to it, bro. You lucky. So dyspnea is difficulty breathing when upon speaking to. So if you say they have 1 to 2 word dyspnea, look, thank you. I didn't want to say nothing. No, y'all, please, if y'all don't want to talk out loud, that's perfectly fine. Just let me know that y'all are typing something and then type an answer out, because I won't be like, hello. No. So if I'm talking to you like this, that's 1 to 2 word dyspnea. That is notable reason why you provided oxygen. You don't need medical direction for that, because it's already going to be written in your protocols for y'all to know those, or to know what they say. Oh, it's not going. Hang on. All right. So oxygen, some of the precautions with oxygen administration. High concentrations of oxygen have been found to reduce systemic coronary artery blood flow. High concentrations of oxygen have been found to increase tissue damage, free radical production. Now, I put that in there because that is going to be over a long period of time. So if somebody, we call them blue bloaters because they have respiratory issues, and that is a hereditary, that they already know that they are hypoxemic, they are hypoxic. They are always hypoxic. If you provide them high levels of O2 for a long period of time, it's going to potentially cause damage because their body ain't used to all that. They not used to breathing that much oxygen. So knowing that, and if the person tells you that, you may have to, if you're on a, let's say, out of town transfer with this patient, that's a 3-hour ride in the ambulance, you may have to adjust your oxygen just deliveries. And it's okay before you take the call, and you be like, hey man, I'm gonna step out here and make a phone call real quick before we get on the road. Call med control and be like, hey doc, look, I just want to double check some of, if you can make sure if I'm reading this right. And just ask questions. They would lots rather you ask and be confident about your question versus be like, well, I didn't know. They said put them on high flow O2 the whole way there. Well, you just gave this blue bloater 15 liters of nasal cannula or non-rebreather for 3 hours. They're gonna look like a blowed up fish by the time you get them there, because their body don't know what to do with it. Oxygen administration differs in medical versus trauma patients. This is for your knowledge. These big ones on here, these big screens like this, they're not on your test, but it's gonna help you. So medical patients should have a SpO2 of 90% or higher, 94% or higher. Trauma patients should be supplemented with oxygen at a 95%. So, and I've said that medical should be supplemented. So what I would like for you to think is not every medical patient needs a non-rebreather. And y'all remember, that's the one that goes over the mask that has the little bag at the bottom that you have to inflate. Not every patient in the world that you're gonna get needs those. So if you put them on a 3 liters nasal cannula, the little prongs that go in the nose, it's okay to do that as long as they're over 94% of oxygen, or a little, or under, I'm sorry. So trauma patients, you need to make sure that they have any trauma patient you go to should have 15 liters of non-rebreather the entire trip. Okay, just something y'all can remember there. All right, so when we talk about oral glucose, this is what feeds the body with energy. This gives your it's the fuel that gives us the energy. So when we get that fight or flight dump of epinephrine, there's no more reserve. That's the reason why after a traumatic incident, or you got this crap scared out of you, you're just like, oh my God, I'm so tired all of a sudden. And that takes time because your epinephrine has to wear down and wear off, because the STP is not there. It's gone. You done used it all. So that's what your glucose is. But you provide oral glucose. This provides this brain cells uninterrupted supply of glucose. Oral glucose may be administered to diabetics with low CBG levels. Okay. Well, you got to know that first. You can't just walk up and be like, whoops, diabetic, giving them a amp of oral glucose. Well, no. Now you may have made them You could have put them in hyperglycemia. So prick their fingers, find out what the CBG is. Upon remembering of your protocols, if they don't qualify for it, don't give it. If you don't know, give it. Just make sure you know what your protocol say. All right, so activated charcoal is the dirtiest crap that's out there. If you want something to go everywhere in the world, this is it. We had a friend fireman of mine, was firefighter paramedic. I got married right after we got out of paramedic school. Well, we took 3 big old bottles of activated charcoal and shoved in the air vents of his car. So when him and his wife left, they were it is the finest material. It is, like when the cops use that fingerprint dust. That is probably some of the finest stuff I've ever seen in my life. Well, this is about the same thing. It goes everywhere. They hated us. Like, this dude didn't talk to us for like months. Oh well, it'd been all right. So I can't imagine giving activated charcoal or oral glucose to a dog. That's got to be rough. But
You end up
when
wearing
you
more
give
than
it-
you administer.
yes, it's the same thing with an adult, because once they realize that they got to swallow this, and I'm just gonna be blunt, y'all, this nasty ass medication, and if they go, well, guess what? That shit just shot all over the place. There's no way to give this and stay clean. It's not. It's gonna be all over you.
Projectile
So,
vomiting.
if-
It's awful.
Bro, it is. And then it's all black and it has this odor. Once it gets in the body and gets wet, it's oh, y'all got me. Y'all have at least, some of y'all have at least seen that. So anytime you give activated charcoal is anytime that they ingest a poisoning, and what you're trying to do is get that poisoning or overdose of medication to bond to this activated charcoal. Well, they're going to throw it up. You can't suction it out fast enough. You can't, I've been trying to speed to the hospital as I'm giving this crap. It's coming up. I've had suction canisters there. I've had the big throw up bins. I've had garbage cans. You get there and you're like, man, I hate my life. It's everywhere. Like it's behind your ears, it's in your ears, and it's not like it's coming from the patient. It's just that fine of a black charcoal. I think I've made the point, and y'all have helped me there. All right. So some agencies do allow you to give aspirin. So, and the reason why we give aspirin is to potentially for a, oops, sorry, y'all, I'm playing with the pen. So if that's loud, please let me know. So if y'all give aspirin due to a heart attack, or y'all can, I want you to know about this medication. Obviously, it's right there. It says patient with chest discomfort related to a lack of oxygen supplied to the heart. Well, it could be from COPD, that is hereditary, or that is well known, or it can be from a CHF issue, congestive heart failure, or just a random a heart attack. We give it too, 81 milligrams. That's what we give. That's our base dose. But you need to understand why we give that. And what this may help is it could potentially help thinning the blood and keep the blockage of coronary arteries by interfering with the platelet function. So we want to affect it down to the blood level. Well, how long does it take for aspirin to get to the body? Well, hell, I don't even know that. That's just what I'm told to do. But that's fine. But if your agency allows you to give it, I want you to know why. Why are you giving the 81 milligrams of aspirin? Well, it's because if they have any type of chest pains, cardiac related histories, we give ST elevations, all that other stuff. I want you to know that's the usage of this medication. And I think we talked more about this in some of it. All right, so medications. These are inhale bronchodilators. Phone keeps vibrating and there's nothing like at all there. Sorry, y'all. All right, so these meter dose inhalers, they are like your asthma inhalers. They are your I mean, it could be anything. It could relate to any type of just an inhaler. So these are what you need to do is prescribe. Make sure they're prescribed to the patient with, and they do have chronic respiratory disease. EMTs may only administer medications that are beta-2 agonists. You may hear that on a test. I don't 100% know. I have not read those tests for this chapter. And is designed to dilate the bronchioles. Some of the drugs that are included are albuterol and levobuterol. Levobuterol. They're in the same family. All right. So here's what a a beta-2 agonist is. Beta-2 adrenic agonists are a drug used as a mainstay treatment for respiratory disease, such as bronchial asthma and COPD. Albuterol is used to prevent and treat difficulty breathing, wheezing, shortness of breath, coughing, and chest tightness caused by lung disease such as asthma and chronic obstructive pulmonary disease, COPD. Levobuterol is used to prevent or relieve the wheezing. That's basically the same thing. So levobuterol is a class of medication called beta agonist. It works specifically by opening the airway passages to the lungs, making it easier to breathe. It's going to the bronchioles and trying to open them up, because just think about this. During an asthma attack, that is basically like your lungs having a seizure. They're closing up, and you got to get that medication in there soon enough so you can dilate those bronchioles, alveoli, and the respiratory tree. Does that make sense to y'all? I know I added that, but I wanted y'all to understand what a beta-2 is and why y'all give it. Now, not many agencies already have some of these on your truck. If the patient has that medication, they have their own albuterol, you can assist them giving it. And I mean assist as in they hold the medication, you hold their hand, help them put it up to their mouth, and you help them squeeze it. Now, what you need to make sure is right name, right dosage, right amount. There's 5 R's, and we'll go over those for sure later. But those are what you need to make sure before you help giving this assisted medication. Did I go too deep for y'all, or y'all still follow me? Yes, they're her.
I'm following you. I'll just need you to go back to a few slides later on.
Okay, just let me know. We'll take care of you.
Okay.
All right. All right, so here's one. Inhaled bronchodilators. They are a small volume nebulizer prescribed to a patient with chronic respiratory disease, which is an inhaler. We already talked about that. Y'all know that. Y'all probably seen people with them. You may have used one, then probably should have been yours, but it really wasn't. Can't do that. I'm just telling you that's what you're supposed to do. You can only, again, administer a beta-2 agonist. Remember what those use. It helps dilate the bronchioles. And again, we talked about that. I don't know why I copied that slide. That was twice. Okay. So now we're moving into the heart. So nitroglycerin. So they make several different dosages of this. They make a metered inhaler, they make a peel, and they make a paste. So when we talk about this, the only thing that they want EMTs use is the spray. That's about it, because that's the simplest it can get. All right, this will help dilate blood vessels to reduce the workload. So what you can imagine is, let's see, so your heart pumps at a 3-liter Coke bottle. So everybody can follow me. Y'all know how big those are. Well, during a cardiac event, everything is constricted, and now you're working out of a 16-ounce Diet Coke can or bottle. So what we want to do is we want to try to dilate those blood vessels so it can help with the workload of the blood that is needed. So we're trying to dilate that, and this medication of nitroglycerin will help dilate those vessels. Hypotension is the biggest side effect that we see. So it will drop your blood pressure. I've told many people, and I'm doing them out in the field with this way, if you don't feel comfortable in giving this medication, you need to let med control say, hey, I'm not comfortable with this medication because I don't have the ability to help them if they go hypotensive. So that's knowing the medication up front. So must not be given to a patient who has already taken the drug for erectile dysfunction. Bad idea, bad idea. Because what that is, that's a constrictor also. That is, tries to shunt the blood. It's going to constrict it. All right. So that is the biggest contraindication that we come to is erectile dysfunction medication. Now, if they tell you and they start having, so the reason why it causes chest pains is because it constricts the blood flow. Well, why they took this little blue pill is to increase the workload. It's going to increase the workload of their heart. So that's probably what's going to be the cause of their chest pains and or heart attack. But they're not going to know that if that's their first time or they've never used that drug or they just took it because a buddy gave it to them. So be ready for that, because if you give this medication and they've had that, they're going to go into cardiac arrest. Just thought I'd let y'all know that. That's kind of a tidbit information. All right. So epinephrine. When they talk about epinephrine here, what they're talking about is the EpiPen. They're not talking about like you're going to give epinephrine for cardiac arrest. So that's the big part there. All right. So epi is used to treat severe allergic reactions, anaphylaxis. It does help reverse the vasodilation, bronchoconstriction, and increase capillary permeability through actions on the sympathetic nervous system. So again, what it's trying to do is trying to dilate all the vessels, and it's trying to open the constricted airway. Okay, so we know epi, and what it's going to do is going to speed your heart up. Patients with severe allergies can carry their own epinephrine auto-injector. Again, if you have to help them, you put the epinephrine thing in their hand, put your hand around it, and assist them in jabbing in their leg. Now, we don't have just spare EpiPens on the truck because that's expensive. But we have small dosages of epi 1 to 1,000 and 1 to 10,000 on the trucks. They're multi-dosage vials. Your paramedic just needs to make sure they grab the right one, the correct epi, and the correct amount, because it's not going to work if they grab the wrong one. I promise you. All right, so Narcan, here we go. Obviously, y'all have all heard this. This is a huge thing in the papers, the news. You can buy them at the corner stop and rob, the CVS's, the Walmarts. This is basically for an opioid overdose. I mean, heck, you got drug users that are carrying around with them and tell their friends, hit me with this if I quit breathing. Well, I guess that's called preparing. But if they're too high, they may use it on themselves. Who knows? Naloxone is a competitive opioid agonist that completes the same receptor binding sites as the opioid drug. So what it's trying to do, I'm going to use it as smoke. So basically, smoke, when it enters the body, it grabs and eats the oxygen molecule. So it's the same thing on a Narcan. So if you take, let's see, a pill, if you take too much of that pill, what it's trying to do is this Narcan is trying to bind to it and fill the receptor sites with Narcan. So if it's possible, the Narcan will get into the receptor sites and push out the opioids. Well, now be prepared for this. It depends on how fast and how much of the Narcan that is given this patient's going to act like an animal. They are going to be raged. They're going to want to fight because you just took away their roughly $1,000 high off their meds. Well, guess what? Not your problem, but guess what you better be prepared for? A fight. That's why I don't like giving it intranasally. I like giving it, well, I like giving it intranasally, but at times I won't give it the whole meter dose. I like giving half now, half a little bit later when they wake up, so you're not fighting. I'm done, got too old for that crap. Narcan suddenly reverses respiratory depression, hypotension, and sedative effects created by the opioids. I've given this drug nasally to many people that have gone into respiratory failure, given them the aerolized nasal dosage, bagged them for a minute or two, and they've come around. I didn't have to do anything for their respiratory drive. I just had to get that drug taken away from their system, and their body automatically reset it and went, I need some oxygen because it's hypoxia. So the point of this drug is it's Narcan, naloxone eats up the opioid and it does away with it. And that's why the Narcan is so popular. Now it will not work on regular like marijuana and stuff like that. It won't work on it. Just not what it's worth. Only for an opioid. Let's see. All right. Talk about medication names. So we have a generic name as a simple, clear, non-proprietary name like ibuprofen. So the trade name of it is one that you may know more of Tylenol. So these, they have chemical names, they have trade names, generic names. Yes, the generic is 99% of the time cheaper, and that's what we go for because some insurance just don't pay for name brands. Some insurances don't like to pay for anything, but you gotta have it. And the way that you can remember this is the trade name is always capitalized. See, in Tylenol, capitalized. So the generic names are never capitalized. Now, I don't know if that was the point back in the beginning, but it is sure as hell helpful when somebody hands you a bunch of meds and you're looking at them and you're like, bro, yeah, I don't know what that is, but you don't want to sound like an idiot. And you start reading it and you're like, oh yeah, well this, this is what you take this for. Oh yeah, I remember. I'm gonna say it works half the time. They just think that you're right. Okay, so prescription meds are supposed to be only distributed by pharmacists, and they have a nurse practitioner, a PA, a physician sign these medications. So they're script forms. You can have it sent straight in verbally or electronically to your drugstore. But those are the ones that mainly can write their drugs. Now, we can break it down. You can have psychiatrists write certain drugs and psychologists write other type of drugs. They can't, I don't remember the difference, but to get a prescription has to come from the pharmacy. If you take somebody else's medication, that's against the law. All right. OTCs, over-the-counter meds, that's cool. I'm pretty sure y'all are some brilliant folks, but recreational drugs is not the one I'm going to use to go out there and run around and play sports. We're more talking like the good stuff, like the heroin, the cocaine. You can have some of your herbal remedies. Prime example, I'm an essential oil fan. I know some people probably hate them, but I use essential oils when I have my migraines that kick in. I have a certain mixture that I use. My wife has concocted. It works for me, and it may not work for somebody else, but I like my herbal remedy. You have your enhancement drugs. We can talk about the little blue pill, or HGHs, human growth hormones. Vitamin supplements can either be oral or injections. You can have like B12 injections. You can have biotin injections. The only bad thing about biotin injections is they burn. Like they burn pretty bad. So if you ever had to get that, make sure they throw a little bit of lidocaine up in that thing. And then you have some of your alternative medications. I refuse to talk bad about it, but you have some of your like off the beaten path medicines, some that are may have religious effects or remedies, different things like that. That's the reason why they work in certain areas and they work for certain times. And I'll never argue that. That's like I don't ever talk about the Native Americans. That's a whole different realm. Medications that patients take can be pharmacologically active and cause an effect. So ask the patient about all their medications or drugs they're taking. If you happen to know that just because you've been there for a while and you start to learn these different drugs, and you're like, you know, I don't think you should be taking your low blue pill. And how often do you carry your nitro? Oh, only when you need it. Well, just because you have nitro and you've carried it for the last 15 years, when's the last time you refilled that? Oh, well, never. Well, you should, because that medication becomes powdery and then you're not actually taking the correct dosage. Uh, Sorry, I know I told you I like pharmacology and I just get off on these rampages, so I'm sorry about that. I'm trying to get back on track. All right, so different routes of administration. These we'll go over. We'll a couple of pictures in a few minutes that'll help. Internal medications enter the body through the digestive system, and parental medications enter the body by some other means. I would write that down if I was y'all. That's probably going to be a next question. If you're transporting a patient going down the road, do not let the patient attempt to get their medications because the activity may increase their discomfort and aggravate the medical condition. If they're like, oh, by 2 o'clock every single day, I have to take these medications, it's 150 and they're trying to dig in their bag, don't let them. Tell them that you need to look at them, write them all down, and that the doctor has to tell you what you can and can't take for what's going on right now. They're probably not going to like you, and that's okay. I mean, I've been called dirty names before because I have an ex-wife, but it's not going to bother you. I promise you, if you've never been cussed at, just wait. You may do it your first day of EMS. But I want you to be very, very, very familiar with your local protocols. That's important, okay? Specifically about your internal medications, these often come in pill or liquid forms, such as like a cough medicine. You may get the little Tessalon pills, the little silver, yellow type looking pills. They help with cough. Parental medications are the ones that are 90% of the time given by needles, injections, that it doesn't have to go through the GI tract. I mean, yes, it will all eventually leave that way because it's got to burn it off. It's got to leave the body somehow or another. But the GI tract will help potentially slow down some medications, absorptions, and all that. But the key part of this one is right here. Be very familiar with your protocols. And this right here, internal and parental, those are very important, okay? All right, so we're going to talk about absorption. I want to know, this is how the body breaks it down and absorbs it into the body, not as in like a topical absorption. I don't care about that because there's only one medication we can use by that way, and that's nitro paste. And I hate that stuff because it gets everywhere. It's just it's sticky. So some common routes of administration, you have your PR, which is by rectum, and PO is by mouth. You will see a lot of that on prescriptions. If you get your prescription and they want you to take it 3 times a day, PO, well, that means by mouth. I don't know why the abbreviations are the abbreviations, but that's it. That's been discovered way longer than I've been around, so no jokes there. It helps to know what medications. You don't see a ton of medications that are PR. You may see PR medications specifically on some children that have seizures, that they try to get seizure medications in rectally. I have given Valium rectally by orders of a doctor one time. That's one time in 20 years. And I was like, I'm sorry, what'd you say? You want me to give it how? You said, wait a minute, you said rectally? So I think we got the wrong number. I think we talking, but I ended up, I ended up doing it, but I wasn't comfortable at all. Some of your other routes of administration, these are for knowledge, basically. You have your IV, which is into the vein, IO, which is then what we can use to drill into the bone as paramedics. You can do a humerus, which is into the shoulder, or you can do IO, which is into the tib-fib area. Kind of gives you an idea right below the knee. You have your subcutaneous. That is where you get like your flu shot goes sub-Q. You get vitamin B12 shots. Those are sub-Q. Anything with deep, basically long needles, as I want that to go into the muscle. That is a thick medication and it works faster by being absorbed to the medication, and that's given by IM. So into the muscle. It's absorbed pretty quick. Just kind of remember the sub-Q is given to the it's given directly into the fatty areas between the skin and the muscle. It has a, when you look at it, you're like, ah, that's still a long needle, but not compared to a regular IM needle. So we do give injections out here, but our injections are only IM. We I would never give a sub-Q unless it's in a clinical setting. Yes, I know I'm in an oil field clinical setting, but more of like a tetanus, or no, not tetanus, but what's the one you get? Did they make sure that it's not a respiratory? If it bubbles on your wrist, I just went
TB
blank.
skin test, tuberculosis.
TB. Thank you, brother. I appreciate that. So TB is given sub-Q. Once you go, I don't know if y'all know this, once you pop positive one time on TB skin test, you always got to take your chest x-rays. And if you've never been exposed to TB, that's some of the nastiest medicine, and you got to take it every day for 1 solid year. I can speak from experience. Some other ones we talked about, inhalation. Obviously, y'all know that's going by the nose to the mouth, the respiratory tract. Sublingual, nitro is also given sublingual. It's very nice to tell them, hey, put your tongue on top of your mouth and put the pill right underneath their tongue. And the nitro spray is also given sublingual, and that helps the absorption process. Now, the good thing is, tell you a little telltale sign about the nitro. If you provide nitro to somebody and they are like, oh my God, I've got a splitting headache. Hallelujah. Because now it's not a cardiac related. Because what it's doing is it's increasing the blood constriction and it hurts. So they will have a bad headache. But if they don't complain of a headache, it's the cardiac related. So intranasally is how we can also give Narcan. So it has a little diffuser. So you have your little vial of medication. You have a little diffuser on it. Most of the time it looks like a little white sphere looking type. And you stick it at the edge of the nose and you squirt half on one side and half on the other side. Again, I'm telling you, be very cautious about how you provide that, because they will, if you quickly take away their high, they will quickly come and try to take your hide. Is how I try to remind people. Just be cautious how you give that. I'm gonna show you this last slide. We'll take a quick break out of that. This is the same thing that's in your books. I just wanted to make sure that y'all understand those, the different abbreviations: sublingual, per rectum, by mouth, IV, IO, IN, IM, sub-Q. Those continuous, those are the different things that I just want y'all to know. They may ask you, what are some of the routes that are by, medicines are given? Well, these, that is 3, 6, 9, 10 of them. If they list something weird, you know that's not the way they're supposed to be, because that's not what you learn. So that's all I'm gonna say about that. Guys, I know I don't want to dive off into something else before we take a break. So I'm gonna take a break early. I'll give you guys 10 minutes, and we'll get back into it. Rebecca, don't forget what you wanted me to go back over, and then at a later time, if that's cool with you, I'll make sure to hit that proper. Cool deal?
Yeah, that's good.
All right. All right, cool deal. Well, all right. Well, I'll see y'all in 10 minutes. 6 after 7. All right, folks, fun time. 10 minutes flies by super fast. We're going back into here. I'm not saying I'm just ready for bed if y'all feel me. So dive off of
Hey
here.
man,
All
sounds
right,
good to
so
me. Let's go to
medication
bed.
form. Bruh, I'm woe out, telling you. So medication, the form of medication usually dictates the route of administration. We kind of dove off a little bit about that. We know if it's pill form, liquid form, syrup form, you kind of understand already. So manufacturers choose from to ensure proper route of administration, time of administration, medication should be in the bloodstream, and the effects of target organs of the blood system. So that's the reason why sometimes you'll get medications that they say, don't take this medication and operate heavy machinery. Well, it can make you drowsy, or it can make you, fishy in the head. Then they'll give you some that they say, hey, take every 6 hours or every 12 hours. It's because they want to, let's say, like a steroid pack. Everybody's had a Z pack. I guarantee you at least once in your life. So if you've had that steroid Z pack, what we're trying to do is we want to give you a dosage of 500 up front, and then the other pills are 250 milligrams each. So what we want to do is load your body with a loading dose, and then maintain it at 250 to fight that white blood cell count. That's that infection, and that's how we dose the medications out. So because that's known, we know that this medication has a target. We know that the target is set to a certain point. So what we want to try to do is the doctors know that, and we're like, okay, well, if we load dose the patient too much, they may, if you get too much, your kidneys are going to filter it out. So you may pee it out versus because it's too much of a loaded, too much of a high dose there. Tablets and capsules. So the big difference here is most medications are given by the mouth in a tablet or capsule form. So they dissolve differently, and that's the reason why certain capsules and the gelatin shells are filled with the powder and the liquid forms, because most time your gelatin capsules are going to dissolve a lot faster than your medication. Well, that also affects on what your gastric acids are in your body. Are you, maybe have you eaten? Are they filled right now? Are you hungry? Your stomach's empty. You don't ever really want to take medication on an empty stomach because they can all make you sick, and you can have some side effects from them all. Tablets often contain other materials that are mixed with the medications and compressed. Um, they can make Tylenol instead of that little round oval pill, or sorry, not oval, but the oblong pill. They can make that a heart if they wanted to. It's just a press that's pressing the powder into the form of that pill. It's just the route. That's just the pill design that they chose. That's what they stick with. Most of the time, you will see some of your illicit street drugs. They will be in different. They will be in a different shape than what you normally get, because those forms, those like the presses of those pill forms, are pretty well hard to come across, because you don't just get those made because you want that pill press. We'll talk about solutions. So some solutions need to be kept in the dark. They don't need to be. They need to be cold. Solutions can almost be given by any route, but given by mouth, solutions may be absorbed from the stomach fairly quick, because the medication's already dissolved. It's already in the liquid form. I don't need to break it down no more. It's right there. There are some solutions that we as paramedics have to mix prior to giving, so you can give it IV, IM, or subcutaneous, but we have to mix those forms up from a powder substance to a liquid substance. So you're going to take a normal saline mixture and dilute the you're going to mix it up into the other the powder form, shake it up real good, and then we'll give it out that way. Suspensions separate if they stand or they're filtered. It is important to shake and swirl suspensions before administration. It's just like the same thing as taking orange juice out the refrigerator. You gonna drink it without shaking it? No, y'all are not going to, because that's not what y'all were told to do when y'all were little. You shake it up really good, dispense it up, because after a while it will, if you leave it sitting there long enough, you'll have the juice go to the bottom, the water to the top, and the pulp sits at the very bottom. Y'all know you don't just drink orange juice like that. You shake it up. Even out here, that stuff don't last long, but everybody shakes it up. It don't matter if I just saw you shake it up, put it up. I'm gonna shake it up again. Part of it. Same thing with certain types of suspensions. Any liquid form medicine, you should shake it up, try to help move the particles around a little bit better. So meter dose inhalers, that y'all have all seen these pictures. Y'all know what that looks like. They deliver the same amount each time. So no matter how many times I press this, it's going to give out 2 milligrams per spray. I don't hold me to the 2 milligrams, but that's every single dose. And they already know by trials, and errors that this will hold 30 puffs. You know, somebody can tell you that they have to use it a lot more than I do, and exactly how much it'll hold, I don't know. I've never used one of these. I've seen other people use those. And it's the same thing here. They break those particles down into droplets. So that's a vasodilator. And what they want to do is get those droplets into the heart, into the lungs a lot better. Spray canisters direct into substance through the mouth, into the lungs. We should know that by now. An MDI, which is also known as a metered dose inhaler. You may see that later on about the meter dose. It's not something I desire y'all to know, but that is another abbreviation of a route of medication. Not route, but a dose right there. I'm sorry. So topicals, we talked about this. Ladies, I pick on y'all. Let's say suntan lotion, go to tanning beds. You know your lotions and creams and ointments. People that like their lotions on them, they know that's basically, it's a topical. You apply it to your skin. Some medications that we use out in the field, you guys will never use hydrocortisone, Neosporin, or calamine, because even those are over the counter. You may be able to help a patient use their own, but we don't carry those on the trucks. Okay. I carry hydrocortisone cream out here, but I operate in a different remote level, so I have a lot of different things. We have the ability to do a lot more than just a regular street paramedic, so that's why we have those. I have more Neosporin than you can shake a stick at, along with hydrocortisone cream. We don't carry calamine lotion, but there's a lot of different things that we carry versus streets. What I want you to know here is what a topical medication is. That's it. Is it one that goes on the chest? Is it one that goes on the arm? It doesn't matter. It's just a topical cream. That is our biggest thing. Transcutaneous medication. So this is what I want. This is to be absorbed through skin. Remember when I was talking to y'all about nitro paste? So what we do is we measure out how much we want on the chest, and we place it right above the heart on the left side of the chest, and then we have it covered. Most of the time we do about a 2-inch strip, 2 inches wide, maybe an inch and a half tall. And we cover it, and we write the time that we put it on there, because that stuff, we don't want it. I mean, if I accidentally get nitro on me, it's gonna create me to have some side effects of it too. So these are transdermal, and the reason why they're transdermal is because they're absorbed through the skin. They do affect the heart a little bit easier. It's not a metered dose of an inhaler or a pill that I have to go through. It is a continuous absorption over a period of time until you wipe that medication off. So it's not like I'm going to be like, it's all gone. No, your body just absorbs it over a time frame. That's why we, as this remote section, like to use it. The topical cream is a whole lot better than just giving the pill or the aerosol. Now we have them all, but that's our go-to choice. The very fourth bullet is super, super, super important. If you touch the medication with your skin, you will absorb it just like the patient. So you may have that badass headache that's gonna give because you wiped your arm across, and the medic was like, bro, I just told you the medicine was there. Maybe you were busy, you were in a hurry, you didn't pay attention, you just didn't hear them. those are all some of the things that's effective. So just remember that any topical cream that is not made or transcutaneous cream can get on you, and you have those desired effects or adverse effects because it's there. I don't know what else to tell you. Yes, so lidocaine patches are considered transdermal. So they are absorbed. It's just like the fentanyl patch. They are absorbed through the skin. Gotta make sure you got the prescription for that. Those will screw your world up because that is a Schedule 4 narcotic. So be careful about those. You will see your patches, your creams, and the patches are they have a certain amount of dosage. I don't know which dose are on the lidocaine patches or the fentanyl patches. I think they all range differently, but they are considered the same thing because it's absorbed through the skin over time. All right, here's some gels we were talking about. The semi-liquid, as you can see in the picture, here's your glucose. That's your oral glucose. Just make sure when you give something that is a oral gel that the patient is awake and can swallow. If they're semi-conscious and they're just blah, and their mouth all over, don't be sticking that in there. They're gonna choke on it, and then you be like, "Oh, my bad. Let me get that suction, get that thing out there." So only give it when they're semi-conscious. So we talked about gases. So the majority ways that we're going to give it is through a non-rebreather because we're assisted the ventilations with 100% of oxygen. We're going to be using a non-rebreather mask or a nasal cannula. So the non-rebreather is the mask that goes over the nose and mouth and has a reservoir bag. The bag valve mask, BVM, and boo bag is what we hold in the EC pattern. Y'all remember that from the cardiac when we were talking about cardiac arrest and all that? They're different, but they provide it the same way. But on the bag valve mask, I'm assisting ventilations with supplemental oxygen. The nasal cannula or the nasal prongs that goes just inside your nose, and they tickle the crap out your nose until you get used to it about 10 minutes later. Outside the operating room, most commonly used is oxygen. Some agencies, I know there's a place over in Alabama that has nitrogen on the truck, nitrous oxide, sorry. But they have that in the EMS setting. That's uncommon, but they use it pretty rigorous over there. I'm not super familiar with the nitrous oxide, so I can't really tell you. I just know that they use it. So,
Keep the patient
some
calm.
general steps. I'm sorry, who? You said what?
Calm the patient down.
Thanks, right. Yeah. So I know that it will help with that. And that's a very good point. But I don't know like the settings. I don't know how much they provide. I've never had the opportunity to use it, but those agencies I know that I've spoke to over time, they love it. They absolutely say it's the best thing that they've ever had on their truck. So I wish I could tell you more, but I've never had the exposure of that medication. So here is the rights of medication. I'll go over this a little bit more in the other slides because I wrote this down. Hint, this is super duper important for you guys. You need the right patient. So you need to ensure that the patient who needs this medication is the person who receives the medication. Yes, it is. If it's in black and white, it's in an education book. Guess what that means? It's happened at least once. Right medication and indication. So you need to verify the proper medication and the prescription. Is it this patient's medication? And is it the right medication? You want to verify the dose, verify the form and dose of the medication, the right route. Make sure you're giving the medication and the correct route that it is desired to be delivered. The right time. I want you to check the expiration date and the condition of the medication. I don't want a pill to be in a powdered form. that's not giving me what I need. I need it to be in the true pill form. When it says right education, inform the patient of the medication you intended to administer, include any likely adverse effects or unusual sensations he or she may experience. And that is important because you need to inform your patient of potential outcomes. What is going on? What is the deal? What can I potentially affect me from this medication? All right. The right to refuse. The patient with decision-making capabilities. They need to be fully conscious. They need to be awake, alert, and oriented to person, place, and time. They can make the decision to decline or refuse the proposed intervention or medication. And then the last one is right of response and evaluate. Sorry, that's not the last one, but monitor the patient's vital signs, mental status, signs of perfusion, respiratory, and effort after medication. Assess the anticipated response and observe for any adverse reactions. Right time could also be for how long has it been since the last dose. That is correct. Is it time to give this medication again? That's why it helps you to know what your protocols. Most of your fire departments around the area, if they don't transport patients by ambulance within a fire department ambulance, they most of the time fall underneath that jurisdiction of the ambulance service and use the protocols that are set in place by that ambulance service because that's their med control director. Some other places do not do that. They fall underneath what the state has set for them and they go that way. So know your protocols, hence to that. So your right documentations. Document the actions and the patient's response. All of those needs, all those 9 of those needs to be documented every time you give a medication. Now, I'm not expecting you to give oxygen and be like, oh, I need to look on the bottle and see when this bottle was filled with O2. No, that's not, no. But make sure you deliver the right dose of oxygen via the oxygen delivery device. So if you give it through nasal cannula, that is a 1 to 6. You don't want to be giving it at 15 liters per minute because their nostrils are going to look like a hot air balloon trying to blow up. I promise you, this is what it's going to do. So that's what I mean by that. Does anybody have any questions so far? I feel like I've been rambling. I know, Rebecca, I know you do. I haven't forgotten about you. But does anybody have any questions of where we are right now? All right, I'll take that as a no. Circumstances in which the medication may be administered. All right, so this is when you, as a provider, can give the medications. All right, so peer-assisted administrations, patient-assisted administrations, and EMT administered medication. Sorry, and that is again determined by your local protocols and what your medical director allows. If they say, hey, you can give nitrous oxide, well, okay, well then guess what? You're gonna give it as a basic, even though you didn't learn it. You're gonna learn that through your agency, okay? So peer-assisted means you administer medication to yourself or partner. So for example, if you were exposed to a toxic agent, you need to fix yourself. I mean, I got some terms for that, but I don't want to say it. So it's probably not the most appropriate thing for me to say. But a patient-assisted medication is when you help the patient with taking their own medication. So if they have an EpiPen and you get there and you're like, oh, Jesus, they need that. They need to get that medicine. What do I do? Hold on, I gotta unlock it. Colby, what we gonna do, bro? Logs out. We're gonna talk about him since he ain't here. When he gets back in, we'll make fun of him. So anyway, so they administered when you want to give it yourself. EMT administered medication is the EMT directly administers medication to the patient. Oxygen might be what you need. Oxygen may be the thing. So what you do is you give that medication because that is not something that is given all the time. The patient may be suffering from a respiratory issue, and then you can give that medication depending because your protocols allow you to do that. So oral communication, oh shoot, communications. Oral medications. Just confirm that the patient has an airway, and they can answer your questions, and they can swallow. That they don't have like a J tube or a trach or something, and they're like, I can't swallow. Well, no wonder this medication is not going anywhere because they can't swallow, and I look like a big old idiot now. So that's the biggest part about taking a medication is make sure the oral medication, they have a patented airway. Again, oral glucose. Do not give to an unconscious patient or one who cannot protect the airway. If you consider that their airway is not comfortable, if you don't feel comfortable, if you ask them a question and they're like, don't give it. Don't do it. Because you know that they don't have a patent airway at all times. So you only can give it by mouth. Paramedics can give it IV. That is an AMPA D50, or they can hang a bag of D5W. I'm a big fan of D5W versus AMPA D50. It's to me, it's just easier. Just FYI, just to give you a little bit about that because the medication I said, when you talk about D50, that's the big vial of sugar water, basically, that medics give. That is very necrotic. If you don't know what necrotic means, it can actually eat the skin, the vessels, and all that from the inside out. So I've always been scared of that medication. No matter what, when I give it, I always draw back a little bit, make sure I got blood. I'll push a quarter of it, draw back a little bit, make sure I got some blood. I do that all the time because it's very necrotic. I don't want to hurt this patient. My job is to take care of them, not make them worse. So some of the things that I do, but you can only give it to them and you squirt it between the gums and the cheeks of their mouth. That's it. That's all you got to do. You want to give that whole little vial, wherever it was. I thought there was a picture. Sorry. You want to give that whole little vial. We talked about aspirin earlier. Reduces fever, pain, and inflammation. Contraindications: hypersensitivity to aspirin, liver damage, bleeding disorder, asthma. Should not be given to children. Super duper important there. We'll skip these, some of the ones that we've talked about. So the sublingual medications, the biggest one you're going to talk about here is this one. So here's your meter dose of aspirin. This is your bottle. So the reason why that it is a dark colored bottle is because it is it's sensitive to light, and a lot of people have these vials in their pockets for years and years and years and years, and they just know to carry them because that's what they're told to do, and that's all they're going to do. So increases blood flow, relaxes the veins, and increases angina, pain in cardiac patients. So those are the two different types of nitro. And then, like I was telling y'all have a paste that's more of the advanced and paramedic level. But you can see these two on a basic truck any given day. This one's more likely to be given to you guys to use. If you ever give this medication and it's in the pill form, always, 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 always wear gloves. Take the cap off. Tap the bottle just for the desired amount to come out. One drop, 2 drop, that's it. And then let that be. Then you take that medicine, the cap, and dump it into the patient's hand, okay? Because that decreases the chance of cross contamination. Because I can tell you, I get bad headaches, and this medicine right here is the worst headache I've ever had in my life. So don't ever get that medication on you. So anytime, let me add this right here. Y'all see this right here? Anytime y'all give a medication, not only just this, always check a vitals before and after. Now, I'm not expecting you to go psst, and then check their blood pressure. This is not going to work that fast. But check their vitals at a timely manner afterwards. It's telling you here, depending upon your protocols, make sure you have a verbal order from a doctor to give. If you already have written orders, as in protocols, to provide this medication, that's fine. You don't have to worry about still obtaining an order for that, because you have it in your protocols and it says in writing that you can give this medication. So that's why. It says it may cause mild headache. If you don't have a cardiac related, it will. So that could be changed to will cause major headache. Speaking from experience. We talked about that. We know it goes underneath the tongue. 1 spray equals 1 tablet. So there goes your dosages form. So if y'all read this little piece right here, right down here at the bottom, each little pill is 0.4 milligrams. 0.4 milligrams comes out in 1 spray. I told you it was metered every single time. I just couldn't remember the exact dose. It hit me as I passed the screen. So you want to give this 5 minutes apart. Take a blood pressure before each time and after each time, because you want to know, make sure it works. I told you that. Wear your gloves, know your protocols. I think they want you to know your local protocols if y'all hadn't picked up what we're trying to tell y'all there. So intramuscular medications, we've already talked about that. Let's skip that one. I know y'all are so upset about me skipping that one. We went over naloxone. So here's a delivery that we were talking about. So this is an aerolized device that hooks right up to that amp of naloxone. This is the way it comes in our paramedic bags. Pop the little yellow caps off, screw these together, screw on the aerolized unit, and we diffuse it. Now, again, I keep reiterating this. Be careful of the amount that you give. So I'm calling that as titrate to effect. You can give all of this right here all you want. If you don't value the safety of yourself, the paramedics, the firemen, they're all that around the area, and you just want to get your butt blicked, go on, slam that thing. If they're having difficulty with their respiratory drive, give enough to where they start breathing on their own. Okay. Anytime you give it, you want to also make sure you start ventilating with a bag bowel mask. What that does is it helps push that aerolized medication deeper into the body, because it only works because we want to give it through the lungs. We want to aerolize that medication. Even though you're squeezing it through this aerolizing device right here, I don't want it just sit in the sinus cavities. I need it to come down here to the right and left main stem. That's where I want it, and diffuse through the body. That's the important part, and that's the desired location. We talked about inhalation medications, about the different devices of oxygen. So here's a nebulizer. This is one form of nebulizers. A lot of times you only see these in hospitals. In the back of an ambulance, we have the same device on a non-rebreather. Looks about the same, situates there. And this is where your albuterol, Provenol, I've aerolized epi before, it all goes in here. So, but that's what a MDI looks like, a meter dose inhaler. So these are mainly used on some of your smaller kids. You can take the meter dose inhaler and shove it on the end of this. This is a big rubber piece, and you can squirt it and tell the patient what you want them to do, because this comes from the pharmacy this way. And when that child is ready, they take a big deep breath, and it's out of here, instead of trying to time this to their respiratory breath. So you spray it, and you have just a couple, I mean, you probably got 15, 20 seconds for them to take a deep breath out of there. It's mainly used, like I said, for little kids. I've seen this for elderly adults. It just is very, very helpful. Talk about that. So these inhalers, they do take some time to deliver the medication, because it's a liquid form and a aerolized device. So what you're trying to do is you're trying to aerolize this device. So when you give it, it takes a hot minute. You're looking at 0.5 milliliters of Provenal that's and you've got that thing flowing at 15 liters a minute. So you're probably pushing 8 to 10 minutes to try to deliver that. So don't expect instant relief. You can give the albuterol, Provenal, and all that through a CPAP method. Yes. Somebody say something here. So you can give that medication also through a CPAP. The CPAP it's a forceful flow of oxygen. It's a little bit different than what you call as a medical CPAP that people use when they sleep. This is high flow desired pressure of oxygen. We say CPAP for the ambulance side. Patient's assessment include findings. So when you give a patient assessment of a respiratory issue, this is unless it's a respiratory like a respiratory distress and or a respiratory arrest, take time to listen to your patients. Now don't walk up and be like, oh, can't talk to you until I listen to you. But listen to their lung sounds. You want to know, are they moving air? Or do they have stridor? Do they have croup? Do they just have something in there that just don't sound right and it don't sound good? That's okay to just say, look, I don't know respiratory sounds they have, but they got some noise up in there that is that's not right. But listen to your patients also that have clear lung sounds so you can know the difference. Patients provide vital signs. Anytime you should have a baseline of vitals prior to any medication delivered. I don't care with oxygen. You need to have a baseline set of vitals that includes SpO2, blood pressure, pulse, respirations, and count your respirations. So we remember what the correct respiratory rate is for a certain age group of patients. So if they're 12 to 20 respirations and they're averaging about 18 to 19 to 16, about right for an adult, unless they have a respiratory compromise of some other sort. It's very important to know your baseline to where if you give that oxygen and you're like, oh, they sound better. They sound like they're breathing a little better and they're not breathing. It's not like they're not like they're struggling. It means you're doing something and you note that change inside your report. Because again, you gave a medication, you need to know what the outcome of that is. That is better for clinical reporting systems too. Do not underestimate the importance of attaining through a medical history. Ask questions. Medications are often not taken as prescribed. We know that. We probably have been through some of those times in our lives that we just can't afford a certain medication. Specifically, we come to like EpiPens that are outrageously expensive. We look at your elderly adults that they can't. They're supposed to be on a beta-2 antagonist or a beta blocker for their heart, but they can't afford that extra $75 a month. So just because that they're not taking it doesn't mean that they're not prescribed it. Now, if you ask the right questions and do a very good history exam, you can know some of these questions. Like, okay, man, so what'd you call us out for today? Well, I've been having some trouble breathing. Okay, well, just ask some questions that you're comfortable in trying to get the answer that you need out. And once they tell you this, you may be like, oh, maybe I don't need to give this one. I need to give that one. Knowing your drugs that you're allowed to carry and use on the truck are super duper important. If you use the inappropriate medication, you need to make sure that that's noted and that it's advised, okay? Ensure the environment does not harm or contribute to the ARES. Ensure the lighting is sufficient. I always carry a flashlight on me. Doesn't matter time, date, or year. I always have one on me for that reason. Make sure that you're not stumbling around and try to find your equipment as you're getting ready to give this medication. Get your medication out, lay it out. Lay your medication out and prepare for the administration of a medication. It's hard to limit the distractions as much as possible because it depends on the scene, who's around, what's going on, where, what type of scene it is. But if the more distractions that you can limit, the better off you are. Now, somebody asked in here earlier, I'm trying to look back. Rebecca was talking about using like a pocket guide. It is very beneficial to have cheat sheets until you're comfortable with that medication, but never be afraid to go back and look at those. Just to be like, oh, I haven't used that drug in quite a while. Maybe I need to refresh myself. Maybe I need to be like, well, how much am I supposed to give of this Narcan? I know we've used it on trucks all the time, but what does our protocol state? It's okay to go back and just reassure yourself or recompromise yourself. All right. So if a medication error occurs, provide appropriate patient care rapidly. Notify med control as soon as possible. Follow your local provider, your protocols, and you're probably going to have to notify a on-duty supervisor, manager, some bull crap. You got to talk to somebody. Document exactly the incident very thoroughly, accurate, and honesty. It's okay. I have messed up in my life. I don't know about y'all. I'm not as perfect as I think I am. I think I'm pretty close, but I've messed up. Okay. It's okay to say, hey, bro, I may have messed up. I have given the wrong medication to the wrong patient. Happens. So talk with your partner, your supervisor, your med control. Obtain the opportunity to learn. Don't be that guy. I know I keep using that term in a lot of classes that doesn't learn from your mistakes. If you're non-teachable, you're not good for me. You're not doing me any justice, nor your patient, to learn from a mistake. It's okay to learn from mistakes. We expect our kids, our children, I don't know how old y'all, none of y'all are, grandkids, but you learn by your mistakes to improve. Identify areas to target during quality improvement. You're probably going to have to go through some refresher class, but say, hey, this is what I want to know and be comfortable with by this time. If you got to make goals for some, write-up form because you've messed up, that's fine. Be open to learn a new way, a new pattern, something that can help you grow as a care provider. That's the ultimate thing that we need to know, is that you're willing to learn and that you're teachable. Companies want to be able to have somebody that is teachable, so we can move through this process and not harp on what's in the past, but to make sure we are ready to move forward. Key steps in administering medication. All right, follow these steps in administering medication. Obtain, we talked about that. Dang it, my bad. See, I made this note. I knew it was going to be out of the way. Obtain order from medical director. Every medication EMTs administer or assist with does require an order from a medical direction. It can be online or offline. So, can anybody take a guess at what online or offline is referring to? Y'all can type it. You ain't got to be like trying to talk to me if you don't want to. All right. If somebody wants to talk to you.
Whether it's manual written or you actually have to speak with the medical director?
Correct. So online means I'm talking to Joseph right now. We are on the phone together. So we are online. That's how I can obtain an order. Offline means it's written in your protocol, or it's written in the orders that was given to the patient if you're doing a inter-facility transport or you're doing a out of town. That can be both offline. So if you pick up the phone and call me and I'm your medical director and I pick up the phone and I'm like, it's Dr. Wally, what can I do for you? You tell me what's going on. Hey, this is Chris Wally, paramedic Wally on unit 136 for Gulf of Mexico. I've got a 76-year-old male that's having blah, 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 blah problems. I'd like to see if there's a way I've listened to him. He's got a little crud in his chest. You can hear some rails, a lot of sinus drainage. If it's all right, I can give him a breathing treatment on the way in. If you're cool with that. Yeah, that's fine. Give albuterol, 15 liters over a 10-minute span. See you in 20 minutes. So there's your windows, and then you reaffirm. Okay, Dr. Wally, before we hang up, I want to make sure I understand you. You want Provenal by aerosolized, given over a 15-minute span. Yep, cool, thanks. Have a look. That's it. Just verify what you heard. Understand. Say, hey, I understood what you said, but let me clarify for my benefit. Because I'm going to tell you, if you question some of the docs, they're going to be like, and who are you? And why don't you bring them to my facility? Because they're going to tell you that they're the smartest thing in the world. Them and pilots think they gods. I'm just picking. I hope none of y'all are pilots. Sorry. All right, select the proper medication. I don't expect you to sit there and read the little insert that's put in these medications. But in your downtime, if that ever exists anymore, just know what some of the labels mean. Read the directions that are written on the bottle. If you've got time to read about the specific nitro that your service carries, pull it up on your phone. Read it. It's okay. They may teach you something that you didn't know. So, and medications are going to have several, God almighty, trade names. They're called multiple different. Matter of fact, I'll tell you one that I saw today that I carry out here. It is Metaproxen. Does anybody want to guess what that is?
Sounds like some sort of NSAID.
It's a naproxen. Everybody knows what naproxen is. It's a pain reliever. So I looked at it. I was like, well, I know what Proxen is. And then I was like, oh, come on, Chris, that was crazy. I guess I was having a brain fart. But it's another trade name. But that's the reason why most of the time they have some of that chemical name or the generic, or the trade name built into there. So you know that already on the get-go. But it's a learnable, let me say it that way. We talked about verifying the patient's prescriptions. We talked about the medication. We talked about checking the expiration dates. Highly important. Here's another we talked about. Check for the discoloration or impurities. If it's a liquid in a clear bottle, it should be a very clear, uncloudy fluid. If you pick it up and you're like, oh, well, why is this yellow? Or it's got crap floating in it. Bruh. Don't use it. Just don't do it. Because then you're neglecting the patient and giving a medication that is not good. You can write it up, turn it in, get some new medication. That's cool. It could have been missed on the truck inventory check. It's fine. It's okay. People make mistakes, but don't give that to a patient. We talked about the form, route, and dose. Make sure you give the correct medication, the correct route. And look here, y'all remember this one? The 5 rights: patient, medication, route, dose, and time. As y'all can see, that is very important. Again, look right here, documentation. You must document the dose, the drug, the dose, the route, the time, and change in the patient's conditions. Did they improve or not? If you're given a medication, you have to document your patient encounter anyway on your report. And if you're good, even if you have to write it after the encounter, make notes. It's okay to write on your glove. I do it out here because I can't. If I don't write it down, I forget crap. I mean, I can't do it. I can't remember it all. As much as I try, if my keys were not in my book bag, then when I fly out here, I probably would lose my book bag, my keys, because I can't ever keep up with my keys. So, prime example, I write stuff down. So when I finally have time to work on my report, I got everything that I need written down. The number one thing that you need to write down is the patient's name. That's important too, and how old they are. And then you just make little shorthand notes the rest of the time. So when you go to write all this down, you got that information, or you got to find the piece of paper you wrote on. Because you have to document that, because if you don't document that, that will put you in a big bind with your company and potentially a later court issue. Here's some things I want you to reassess after medication. Now, again, it may be simple as being like, hey, Mr. Fred, everything good? Are you still okay? If he shakes his head and says, yes, I'm fine, thank you. Well, you know that his airway, breathing, and circulation are working. So the next thing you should do is be looking at the pulse and the blood pressure on your monitor, because you should have them hooked up. That's it. That's what you should be doing at all times. So this right here is already being monitored at every time. It's just when you give that medication, you need to be like at 1953, 81 milligrams of aspirin was given at this time. 5 to 10 minutes later, at 2003, you need to reevaluate your patient and just do another vitals check. That's fine. 10 minutes is great. If it's a traumatic patient, you need to do it every 5 minutes. And when you hit code summary on your monitor and you have like 40 blood pressures, sometimes some agencies make you required to write them down, all of them. Some of them may automatically transcribe over to the monitor through Bluetooth. I don't know. That all depends upon your monitors and your service. Here's some other things that will help you as you go through here. Your SpO2, super duper important. Majority of the monitors out there always monitor that, and that's written on your code summary too. If they have any complaints that are different from what their signs of what they originally told you they're complaining of. Now, I've had some patients that moan and fuss the entire way to the hospital, and they may say something hurts different every single time. I just write multiple complaints of body aches. I have been the guy and been called to court. I put multiple complaints of life. That didn't go too good for me in court, but I wrote the rest of my report pretty decent. So, medication side effects. Was there any? Are you not saying that you're necessarily going to write medication side effects dash? You can just be like, note that if you notice that the patient started to have hives after giving X medication that was, advised to be given by med control. However you word that is fine. But if you notice these side effects, please, please, please document. Any type of change in the patient's conditions, better, worse. Let's say the patient went hypoglycemic on you pretty quick after you gave 1 amp of oral glucose 20 minutes ago. Well, it's probably already burned itself off. So they're probably going to go crash down again, and you have to redo that entire process. So you need to note that. What did they get better? Did you give 1 amp of D50 and at ANO times 2, and then after that amp you gave ANO times 3, and they're good, they're ready to go? So that's another good thing there. Document. Here's some other we're talking about pocket guides. Here's the EMS pocket guide. They make a life I can have a penny off every one of these things were sold or I've owned. It's awesome. I can tell you some stories about poison control. Never, ever, ever, ever call from your cell phone. You really want to, if you don't like your partner and they've never called med control, call from your partner's cell phone because they call back every 3 hours for a 24-hour window. Just letting you know that, just to check on the patient. And you're like, I'm a care provider. They're still going to call you every 3 hours. These are the little packet inserts that you find in all your medications, or the pharmacy gives you those. The PDR, we actually have, what is this one? We have the nursing drug handbook out here. Those are pretty awesome. A lot of your human drugs also go into TAC for animals. So I'm not gonna say, I mean, I can't take horse steroids, or I could, but that's illegal. But some of your medications go back and forth. American Hospital Formulary Services, AMA drug references. Those are all different forms that you can help provide different backgrounds. If you want to read about a certain medication, maybe you keep hearing of a particular medication that was given because of you had, I don't know, food poisoning. They give you a medication, you have it, you can Google it, you can look it up. There's a great app called Pill ID. You type in the shape, the forms, the cutouts, the numbers on the pills. It will tell you, it numbers it down to, it can, you can be like, oh, look, that's that little pill. Oh, that's their tech. Why am I looking this up for? Because you just, it's not an original bottle. You find it in the patient and they tell you this is what they've been taking. But I like Pill ID. It's been a really good one to me. So in summary, folks, medication administration is considerable responsibility. EMTs give medications only under medical direction, and that is online or offline. Know the differences. You must understand the indications, contraindications, dose, administration route, and form, actions, and side effects of the medications that you can give by giving your local protocols. Always utilize the 5 rights of medication administration. Always. If you don't know them, please let me know. I will back the screen up so y'all can write them down. I hope y'all took a screenshot of that. I know my slides are different than what is on the Navigate, but that's just because I took time and added to the slides. I also did check today, if y'all need them, want them, or care to, you can also access the last 2 classes of video slide presentations from our website too. So those are there for your resource. The last class and this one are pretty much the same. It's even though it's a new book, I did check all the slides are the same. So when we get into like OB, well, gynecology, for example, I despise gynecology. I hate talking about it. I don't like talking about the chapter. It's just my #1 topic that I hate. It is some very cool information, but I've hated it my entire life. I would rather talk about deliveries than talk about OBGYN. So you may have a guest instructor that night when we get down that far, but I'm just telling you. I've delivered in the 20s of babies. I love it. It's great. I just hate the topic of OBGYN. So that resource is there. Y'all understand we're in a new month, so be prepared that there may be something pop up on Navigate at a certain period of time. Just gonna let you know that. If I'm not mistaken, somebody correct me if I'm wrong, you also have a module. Is that tomorrow? That's Thursday night that the module opens, I think. So be prepared that you're gonna have that time and all that you may need that. You have one more chapter test through here and then the module. So if anybody wants to work on potential retake, because you only get one freebie, the way I call it, per module, and then the other ones you have to discuss with me, write some information down and go over that. I will give you your class code, and then I will take the time and sit back and go over Miss Rebecca of what I needed to cover. But for tonight, there is your class code. It is all capital letters. That is SM64 and the @ symbol. That is your code for tonight. Hit that end button. So that's also in your chat. That's recorded also, so you can see that. Does anybody have any questions? I told y'all pharmacology is a lot. I like pharmacology, but I tried my best to break it down for you guys. Miss Rebecca, I see your mic unmuted. What you got?
Nothing right now.
I have a question.
Come on, Mr. Morgan.
Okay, cool. So, excuse me for joining class a little late. I was working shock trauma today.
Don't give no excuses. Come on. No, I'm just kidding. I'm just kidding.
It's just crazy. We had a total of 18 GSWs today, MVCs. It was just really, really crazy. So on this coming up weekend, on was it a Saturday? We just show up at the station.
Yes.
And we just tell them, say, hey, we went so
As long as
go ahead.
Does Rob already know that you scheduled to go?
I guess I gotta send him an email. I guess we gotta let him know which one we're going to.
Yeah, because Rob is the one that is handling all the boot camps right now. So he's the one that can give you a better direction on that. I will help y'all out as much, but I prefer to take a third party out of a question. So if it's something that I know that you need me and I can direct you straight to Rob, I want you to know that. Baby, I ain't going nowhere. You ain't gotta ask. I'm right here in the middle of the Gulf. No, I'm just speaking. If y'all all want to try to get in there, y'all can talk in the Discord about where's everybody going versus not going for boot camps. It may help you out so y'all can meet some of your peers.
Yeah, I tried to post something about who I was going to be like in Alabama.
Oh, that's the one I'm going to.
And there was crickets. Nobody replied.
I'm going to the one in Alabama, so that's good. We'll go to the Piperville or something like that.
The one in Alabama is in Pell City. But you talking about the fire hall?
Is it Alabama? Yeah. What you talking about, Pell City?
Yeah, that's the name of the town.
Oh, yeah, I don't know the town. I just know it's Alabama. That's the one I'm going to.
Okay.
Lord,
so we need to give a ride, right?
Yes, I would say go ahead and shoot Rob a email. I would go ahead and say shoot him some information that y'all are gonna be there.
Hey, Chris, we good? Can I get out?
Bro, you can bounce, bro. I
Bye,
will
brother.
try to unlock the test, but I have to go in there and reform the test for everybody because it's locked into a system. But Chris, if I can get it, I will do my best to open it. If not, I'm sorry, you got 2 hours for it to open.
Okay, thank you so much.
All right, Rebecca, what'd you have, baby? What can I help you with? Be careful.
So going back, because these are the new slides that you added later on, or yeah, because some of the information was a little bit different than the ones that were already posted. So the one that start out with the oxygen slide.
I'm looking. That one? Here's actually the beginning.
Yeah, the beginning, because I don't think I got the percentage down. And then, okay. All right, the next one.
All right, 2 seconds. And you probably want this next one when it talks about medical and trauma patients.
Okay, I got that one.
All right, there's the one that has the percentages.
Okay, yeah, I got that one.
And then
There
it
was
goes
some-
into the oral glucose and all that.
Yeah, the oral glucose. Gosh, can I talk today? Okay, was that it on the oral glucose?
That's it, because the next one's activated charcoal.
Okay. And was there anything else with aspirin? I knew I got patient with chest
one?
discomfort. By interfering with platelet function. Okay. Okay. Yeah, that's all I needed.
Okay,
Oh yeah.
that's it.
Yep, that's it.
All right, cool deal, darling. You have a wonderful night.
Thank you. You too.
All right, good luck on your test.
Thanks.
All right, bye-bye.